Hello, I am Dr. Hisham Muhammad Abdullah, a family medicine physician at the primary health care. It's pleasure to be today presenting a case about diabetic microvascular complication. Specifically, I'm going to talk about diabetic nephropathy. Diabetic nephropathy is a severe microvascular complications occurring in individuals with diabetes. It's associated with increased risk of all causes of mortality, cardiovascular disease, progression to end-stage renal disease. Uh, by definition, diabetic nephropathy is characterized by a persistent proteinuria, usually more than 500 milligram per 24 hours, or albuminuria, more than 300 milligram per 24 hours. It's usually associated with increased blood pressure and decreased excretory GFR. When we implies the terms of proteinuria, we mean increased urinary excretion of albumin, other types of protein or total protein, while albuminuria implies specifically increased urinary excretion of albumin. The microalbumin implies albumin excretion above the normal range but below the detection level by the test for total protein. The early markers to suspect uh, diabetic nephropathy in individuals with diabetes is presence of proteinuria. It implies, especially in patients with diabetic retinopathy. This is highlighting the start process of microvascular disease and definitely increase the risk of diabetic nephropathy. The average person can usually excrete a small amount of protein, but however, whenever there is an excessive persistent protein excretion can be an early indicator of renal impairment. The abnormal rise of excretion of albumin is crucially highlighting the presence of a chronic kidney disease due to either diabetic or glomerular diseases or hypertension. Albumin creatinine ratio test estimates albumin and creatinine in a one-time sample, that's a spot urine sample. Uh, Creatinine is the end product or the breakdown of creatinine phosphate from the muscles and protein metabolism excreted and released in a constant rate by the kidneys. This constant rate, that's a total amount of daily excretion that will reflect, it might definitely reflects the whole daily urine albumin level without the need to do the 24 hours urine sample. So this is an indirect reflection of the amount of protein excreted within the 24 hours. From this table, we can see the normal values of albumin creatinine ratio. The normal in male is less than 2.5, in females less than 3.5. Mildly increased microalbumin uh, albumin creatinine ratio is seen is more than 2.5 to less than 30, and more than 3.5 and less than 30 in female. In moderately increased albuminuria, we can say from 30 to 300. This is a moderately increased. Any amount above 300 in both females and males, this is indicating an overt proteinuria and severely increased albuminuria. How we perform the test? We do the test, actually, we can do a mid-stream test, early morning sample, or even a random sample at the time of presence in the clinic can be used and sent to the lab for investigation. In this diagram, I would like just to explain the process of the diagnosis and screening of diabetic nephropathy. An early urine sample can be used, or even samples at the time in the clinic can be used. A very important point here is to rule out other causes of false positive microalbumin test or protein test, which can lead to false positive test, by ruling out urinary tract infection, presence of blood, or even menstruation in females, uh, exercise within the past 24 hours, infection, fever, congestive cardiac disease. All this could be other causes, has to be ruled out to exclude the false positive test. Uh, in this test, we can see here, if the test is negative, then that the individual will go directly for annual repeat of the test, while increased microalbuminuria has to be confirmed in other two visits in 3 months and 6 months. And if the test is negative, then the patient will be shifted to do the test every year, and that is annually. If it is positive, he will shift to the diagnostic of overproteinuria and need to start the medication. Usually we start with ACE inhibitors medications and need to be evaluated within 2 to 4 weeks for electrolytes and excretory GFR, and then we can do the urine test for albumin every 6 months, and then we can increase the dose and to reach the maximum dose to adjust his medication. Uh, as I have mentioned here, this is the could be the false positive microalbuminuria. It's been seen in these situations, in hematuria, in some type of medication, severe, in fever, in exercise within past 24 hours, urinary tract infection, and uncontrolled diabetes, and congestive cardiac failure. As microalbuminuria or nephropathy is asymptomatic, yeah, there's no symptom, asymptomatic, it makes screening is an essential tool to detect early case of nephropathy. Usually in type 1 diabetes, we do the test after 3 to 5 years of the initial diagnosis of the disease, and then annual investigations is followed. But in case of type 2 diabetes, we need to do the test at the time of the diagnosis of this type 2 diabetes, and then annual investigations can be done. A subject with established retinopathy need to be screened for microalbuminuria. The most common causes of death in patients with diabetic nephropathy. The risk factors for chronic kidney disease usually increased, but there is some initiating factors of risk factors, including old age, male sex, or diabetes. The preserve factors for progression of disease onwards is depends includes proteinuria, high blood pressure, hyperuricemia. Results from some systemic review studies highlighted substantial proteinuria and male sex are a significant risk factors for worsening late-stage chronic kidney disease uh, and to end-stage renal disease. Diabetic nephropathy is a common cause of nephrotic syndrome in adults in US. Progression to end-stage renal disease is up to 80% due to diabetic nephropathy. Most of common causes of death in all phases of diabetic nephropathy is cardiovascular death is rate is increasing albumin urea. According to some studies by Nizar in 2014, Two-thirds of deaths in individuals or people with type 1 diabetes are due to end-stage renal disease, while one-third is due to cardiovascular disease. In type 2 diabetes, death is more associated with other comorbid factors and cardiovascular disease, mainly in people with over nephropathy, even before they reach to the end stage renal disease. That's mean the cardiovascular disease is the most common cause of death in type 2 diabetes. The prevalence of renal failure is about 40% in individuals with type 1 diabetes, and it's about 20 to 30% in individuals with type 2 diabetes. Uh, in these slides, I will just show the most important therapeutic goals to be achieved in management of patients with diabetes. Nephropathy is the optimize of blood sugar is very important to reduce the risk of progression to end-stage renal disease. Optimize blood pressure is an important factor, and monitoring of albumin excretion twice per year using excretory GFR to assist both response to medication as well as progression of the disease. Reduction of the protein and dietary advice is an important factor for people with diabetes, albuminuria. They should be treated with AC inhibitors or ARBs medication. AC inhibitors and ARB and or diuretics used in monitoring serum creatinine and electrolytes, as I have mentioned before, in the initial 2 weeks, and to monitor the baseline of creatinine. If it's raised more than 30% after starting the medication, needs to be stopped. And if hyperkalemia cannot be controlled medically, also the patient has to be evaluated. Uh, at these slides, the most beneficial for patients with nephropathy in terms of progressing of renal functions is to maintain individuals with diabetes and chronic kidney disease are usually at greater risk of worsening renal function, cardiovascular disease, and increased mortality. Hence, an excellent management includes a lifestyle intervention, lowering of risk factors, appropriate drug management. Individuals with diabetes and chronic kidney disease can benefit from a structural educational program. It's an important, which is going to improve the quality of life as well as getting better and even in weight management. Nutritional advices, including uh, management of hyperkalemia, total daily protein, total sodium, reducing of total sodium intake, and all these are important factors. Moderately physical activity and maintaining of regular exercise about 150 minutes per week is recommended, and strong recommendation of quitting of smoking as a very strong association with increased cardiovascular disease and worsening of chronic kidney disease. Another crucial point to manage the blood pressure is to increase the physical activities, quitting of smoking, healthy, balanced diet, management of stress. Uh, Maintaining blood pressure is less than 130 per 130 over 80 millimeter of mercury with AC inhibitors is recommended, and can be titrated by increasing the dose till the tolerable dose, or increase or adding another antihypertensive medication. Type 1 diabetes individuals with established nephropathy with albumin creatinine ratio more than or equal to 3 milligram per millimole can be started with AC inhibitors. Individuals with heavy proteinuria or atypical presentation or unexplained cause of the heavy proteinuria those type need to be further investigated, and a referral or a consultation of nephrologist may be needed, especially if there is any suspect of other causes rather than diabetes to be the cause of nephropathy. The optimal glycemic control and to maintain the blood HbA1c is less than 6.5 is recommended and can facilitate and lower the risk of worsening of diabetic nephropathy. By this, I will come to the end my presentation with my thanks for your kind listening, and thank you very much for your listening.